Welcome to this series with the giants of cardiac surgery. My name's Joel Dunning and we're here at AMEX in Moscow with an absolute legend of cardiac surgery. Bud Frazier, I'm absolutely delighted to talk to you. Bud Frazier, trained with Denton Cooley, Michael DeBakey. You've done 1,700 heart transplants, 1,000 VADs, and you have done the first heart-mate implantation, the first Yarvik transplantation, and really you are the history of artificial implantation. So it's an absolute pleasure to talk to you, and maybe we can start by just telling us about how you developed and evolved the first artificial hearts.
One of my cardiologists counted up a few years ago that I'd done over 1,200 heart transplants. I'd actually never paid any attention to it. But I did when I looked at it, and I did it because I was in a private group, and I was the only academic in the private group, and nobody else would help me. So I didn't do it because I particularly wanted to. And the same for the pumps. I either did them or helped on at least 1,000 of them. But again, if I had somebody to help, I would have, it would have been nice, let's say.
But there wasn't anyone else.
There wasn't anyone else because I was at St. Luke's Hospital, which when I started was a 900-bed hospital. And we did more heart surgery at St. Luke's than any place in the world until 1994 when the Cleveland Clinic passes. It was just one hospital. And we also did more than all of Western Europe until 1984. We did 5,000 pumps in a year. Anyway, so that was one of the reasons I got so involved in pumps, because nearly every day we would have somebody that wouldn't come off a bypass. And I had started in pumps as a medical student. And so I saw all those patients.
And you actually were massaging a young patient, massaging with your hand, wondering why you couldn't turn this into a mechanical machine.
That's true. I got into the whole artificial heart regime by when I went to Baylor College of Medicine. I started in 1963. At that time, there were like 75 of us in the class, and maybe 3 women, you know. And we had to be on a research paper every year, which was a very good thing. We had 2 afternoons a week to work on it. And as we started in medical school in September, they gave us until the 1st of November to decide on our first year research. And I was standing at the elevator in the Jewish Research Wing of Baylor College of Medicine on October the 30th, and a friend of mine from the university named Frank Polk came up, and Frank was what we called a gunner. Then he was one of those guys, he was always way ahead of the game. He's always studying and very accomplished. And I was just the opposite, you know. I went to class when I had to and studied when I had to. But Frank came up to me and he said, "What are you doing for your research paper? It's due November the 1st. And I said, "Well, Frank, I've got another day. I hadn't thought about it." And he said, "I knew you wouldn't have done anything. I've already signed you up for the research project. I can't do it all. I have to have somebody else. And we're going to do artificial hearts with Domingo Leota." So that's how I got into the whole business, totally by accident. Frank actually had an intentional tremor, and as much as everybody wanted to be a heart surgeon in those days, I ended up doing all the surgery. Frank went into internal medicine. He was one of the youngest professors of medicine at Johns Hopkins in the U.S., one of our outstanding medical schools, and there's a wing of Johns Hopkins Hospital named for him, the Polk wing. And as he tragically died of a brain tumor in his 40s. But that's how I got into it.
Yeah. And you were right there in those early days with Michael DeBakey and Denton Cooley, and even when he tried his first mechanical heart, that was in your era there.
Well, I worked, as I said, with Domingo Leota on the pumps, not just the total heart. In fact, most of the work was done on the LVADs, because Dr. DeBakey did do the first successful LVAD. And it was when I was on in service. I remember that woman very well. She was a very brave woman. She was a Mexican from Mexico, and the pump was placed outside the body. And when Dr. DeBakey removed the pump, he did it in the ICU. He didn't take her to the operating room. He just put a bunch of iodine on her and gave her some xylocaine and cut the grafts off as they came out of the skin and covered them up. And I remember watching him. He kept saying, "Hold still, my dear, hold still," in his deep southern accent. But and Dr. DeBakey had instituted the whole artificial heart program when I was a medical student, and was very instrumental in starting the entire program.
And was the intention to have a complete artificial heart, and it was roller pumps in that era?
Well, it was the intention, but as they got into it, they realized it was very hard to get a calf through. They did 8 calves, 2 of them when I was there, and in the laboratory with them, and they all died, and they never lasted a day. But they were on the heart-lung machine for 6 or 8 hours, and you put a calf on the heart-lung machine for 6 or 8 hours and don't do anything to it. Don't open the chest, and half of them will die. But and that was why Domingo Leota started going over to talk to Dr. Cooley about Dr. Cooley putting the artificial heart in as a bridge to transplant. And I said, fortunately, when that finally did occur in April of 1969, I was in Vietnam, which everybody that was in Houston at the time told me that I was much safer in Vietnam in a combat, flight combat unit, helicopter combat. Anyway, so that's how I got in it, and I think Vietnam had a lot. I was in a combat unit. We lost a lot of young people, which at my age I was used to people dying, but not people that I had just had breakfast with, and coming back with their heads shot off and that sort of thing. And I think that's when I really decided. I thought about giving up medicine, but then I thought I'd stay and work on the pumps. And one of the things was that you alluded to. I remember this young Italian boy who I'd worked up as a medical student, and Dr. DeBakey had replaced his heart valve. He was a real nice young man. He was 17 or 18, and he did very well, but he arrested the night of the surgery, and in those days they opened the chest immediately, and I was the youngest and probably the strongest at that time of anybody there, and I'd just gotten out of medical school. I was just out of undergraduate school. I played football, so anyway, so I massaged his heart, and as long as I was massaging his heart, he would look up at me, of course. But we couldn't get it started, so that was very depressing for him, because I thought if my hand could keep this boy alive, we certainly should make a pump that could. And again, I was working with Domingo Leota too.
And really, I suppose the sort of breakthrough of left ventricular devices were the sort of continuous flow devices, and the HeartMate 2, which you helped to develop and put the first one in, really. So maybe you could tell us a bit about how the research evolved into those.
We started working with pulsed pumps, of course, trying to duplicate nature, which is what we do in surgery with all our devices. But and we could make them work. And the first pulsal pump to be approved by the FDA was the one we developed in our lab at the Texas Heart Institute. That was approved in '94. But the problem with the pulsal pumps is they failed usually within about 18 to 24 months. And by the early 80s, I did my first heart transplant in July of 1982. And by the mid 80s, we were doing transplants, and it seemed that the only value of the pumps would be as a bridge to transplant, which of course would save individual lives. But as I've said, Dr. Shumway, who I knew quite well, would always harass me at the medical meetings with the fact that epidemiologically the pulsal pumps were doing nothing but adding more people to the transplant list, which had a finite limit of donors. And that's when I got interested in doing the continuous flow pumps in an effort to make a more durable pump.
Yeah. So you've just given us an amazing presentation all about the evolution of these continuous flow pumps, and you've even shown us the latest evolution, which is a total artificial heart, all just one single pump, which is an amazing device. Maybe you can tell us about that and about where you think this specialty is going with that pump.
Well, I would like to just reiterate something, because there were several reasons that continuous flow pumps were not supposed to work, and the mechanical ones were, it would have to be at such a high RPM that it would cause hemolysis in the blood. And we disproved that with the hemopump, and Rich Walper made that pump in California and brought it down. We put that in a patient in 1988. And its descendant is what we call the Impella pump now in the US, and I was instrumental in getting that pump started as well. But for a long-term implantable pump, Rob Jarvik isn't recognized enough because he was able to make bearings work that were not lubricated. Nobody likes to talk about bearings, including myself, but bearings were absolutely necessary in the first pumps, such as the Jarvik and the HeartMate 2. And because the HeartMate 2 evolved, I was the only medical consultant for both companies. And after the hemopump was successful, the company that was making an implantable pump, by then Jarvik and I had, it's the early 90s, we'd worked on a continuous flow pump for over 7 years, and we pretty much perfected the bearings. I was at a meeting with the Nimbus company, and there was a man named John Moise, who was a very talented engineer, graduated from Cal Tech, which is one of our best engineering schools, and he'd been in the space, and he was trying to magnetically suspend the axial flow. And I was half listening to him, but I finally said, why don't you put bearings on that, John? Because that would be a lot easier. And he said, Bud, you don't know anything about engineering. You can't have a non-lubricated bearing in the bloodstream. And I said, well, you're right, John, I didn't know that. And Rob Jarvik didn't know that. But more importantly, there's a calf down in Houston that's had one in for 10 months. And he obviously not aware of that. So, and that's how the hemopump, what do you call the HeartMate 2 got started. Because they just put bearings on it, and that pump evolved. And it shows how, and it's important, I think historically, we've never written this up, but the HeartMate 2, for a lot of, the company went broke and they moved to Pittsburgh, and the guys at Pittsburgh were good guys, but they hadn't spent a lot of time in research with the pumps. And they did the subsequent development of the HeartMate 2, and they put it in Europe. They put it in 11 patients, and 10 of them died within the first month. And the only one that lived was Michael DeBakey did one, and he took it out in 2 weeks. So you wonder if he needed it or not. I never said anything to Michael about it. But at any rate, they brought it to me, and they'd put the sintered titanium, which we put in the pulsatile pumps to facilitate blood covering, was inside the pump. And when I saw that, I told the engineer to just get rid of the sintered titanium, and it'll be a good pump. And I put the first one of those pumps, the clinical pumps, in November of 2003.
Yeah. Do you remember something of that first patient?
Yeah, I remember him quite well because he was a young boy from the Dominican Republic, and he could barely speak English, and he had no money, no insurance. And of course, in America, there's some good things about. The best thing about American medicine is it's a business, and the doctor and the hospitals are working for the patient. The worst thing about American medicine is it's a business, and the doctors and the hospital are working for themselves. So they wouldn't pay for it, but the company, since they hardly had a choice, but I don't want to impugn them. It was very generous of them to give us the pump without charging. And he did very well, and lived another 7 years, and only died after we transplanted.
I mean, you said a very interesting thing in your talk. You showed us a 4-year-old that had had an LVAD,
Yeah.
and you said actually a transplant's a bad operation for very young people, and you said your experience in children's transplants.
I probably shouldn't phrase it as bad. I just think it's like the early days of chemotherapy. You get a response, but it's not a lifetime response. And of the first 48 children I did from 5 months to 14, between 1982 and 1990, I did about 600 heart transplants doing that, but I did all the children also. And there's only 2 of them living now. And they both have had 3 heart transplants. So we have to try to do better. I don't think it was a bad operation. It was life-saving for the children at the time. This little 5-month-old girl that we did lived to be 13, went to school, and was a joy to her parents. So I wouldn't want to impugn it in that way. I can say it in a medical talk to a bunch of doctors, but I don't want the public to even sue that in, because it's not. It's life-saving, but I just mean we have to try to do better.
And so where do you see the future? So we can implant them, but there are problems with the power supply, and I think you talked about sort of nuclear power supplies or percutaneous power supplies. Where do you see the future going?
Well, Dr. DeBakey particularly was instrumental after the failure of the first heart transplants in 71. Chris Bernard did one in 67. By 71, there were, less than 20 of the 175 heart transplants that were done still living. So there was a moratorium placed on that. And we were working in the 70s to develop, a long-term pump as an end therapy, not as a bridge to transplant, because we weren't doing transplant. And as I told you this story with Shumway, as we started doing transplants again, it became obvious we had to do a more durable pump. And that, to me, is the greatest satisfaction I've had to date with the continuous flow pumps. All of them came from around my desk in my lab, the Jarvik, the HeartMate 2, the HeartMate 3, here's what happens when you get to be 80 years old. The other continuous flow, Heartware.
Heartware, yeah.
See, that's what happens. My mother told me when I was 70 I'd start forgetting things, and she was right in 80. But I developed that Heartware. It was my idea around my desk in 1994 to make a pump that'll go on the right side as well as the left, because we never had a right-sided pump. And the hardware is a good right-sided pump. We've had it in over 8 years in patients, and it can do a lot. And that child, that 4-year-old, it was a hardware pump, which is a smaller pump, and he's 9 years old now, and he certainly would have died without it. I would like to have a pump that could carry him through, and that's the goal. We may end up having to transplant him, but it would be nice if we could have a mechanical pump. The other thing that I think is the future, and the last thing I'd like to emphasize, is nearly all of these patients with idiopathic cardiomyopathies get better with time. The initial treatment for heart failure, George Birch at Tulane used to put patients to complete bed rest to rest the heart. And about 30% of the idiopathics would get better and they would be able to be discharged. And I've explanted a number of these pumps, about 19 I think last time, because the heart had improved. So I'm hoping that will be the ultimate goal, to carry these patients till their heart can improve enough that they will be done. We can take the pump out and spare them a transplant and spare them a lifetime with the pump. Now, also, the only reason these are powered percutaneously, that is a driveline coming out, is we had no funding, and that was very inexpensive to do it that way. We developed transcutaneous powering in the 70s. The Abiacor, which was a 50-watt pump that we put in 17 of them, we powered completely transcutaneously. Yeah. The pump called the Era pump was powered completely transcutaneously. So that is here now.
And why haven't they been a success? Was it a very big battery, wasn't it? Or?
No, it was just, let us say, back to my original statement about American medicine, I used to harass these various companies once they became commercialized to power it transcutaneously. But that would have cost them about, I think, $3,500 more. And they were selling the pumps percutaneously. And in fact, it's just business. As one of the presidents of one of the companies said to me, just to quote The Godfather, which I said, it's nothing personal. It's just business, and I could understand that, but now we have to develop this transcutaneous power. The sad thing is it doesn't need to be developed, it's already been done. And because in America, the government doesn't do anything, but they issue RFPs, requests for proposals. And the original request for proposals for an implantable, long-lasting pump, when we weren't doing transplant, included you couldn't break the skin. It had to be transcutaneous. It couldn't be percutaneous. So that work was already done in the 70s. We'd already done all that transcutaneous. And we developed a nuclear plutonium-238 pump the size of my thumb. We put it in a bunch of baboons, and you never wanted to get in crosswise with the baboon because they're strong and they're mean. And they didn't like being there. But we put it under to see if there would be some difficulties with the heat production, which was obvious. There never was any, and a plutonium-238 battery can power a 50-watt artificial heart for 82 years.
No.
And
Really?
the pump that we're working on, which is developed by an Australian named Daniel Timms, which just has one moving part, and is totally magnetically suspended, is about 10 watts.
Oh my God.
So,
and how big is that plutonium?
It's about the size of my thumb. It's a little bigger than my thumb. And as I said, all the toxicity work was done. We were worried about, and there were over 2,000 plutonium powered pacemakers implanted. you know,
Right.
and because they never wore out.
Yeah.
And there was a man named Rappaport who wrote a number of papers on it. He was a very advocate of the core atomic pacemaker, and there were never any problems with them long-term in patients as far as increased malignancies and the things that we were worried about. The one thing about the baboons I remember the best, somebody had the idea to bring a black and white TV in, because the baboons were always mad. And they loved to watch the black and white TV. They particularly loved the soaps. And heaven protect you if you got between the baboons and the TV, you would hear their wrath. Anyway, we've come a long way. I think we will still have a long way to go. We've had these pumps in over 15 years now with one pump.
Wow.
So the durability issue, none of the pumps have been pumped to mechanical failure. They've failed either because of improper or kinking in the implant, or because everything has to be lined up perfectly, or infections. They get a lot of infections with it. That's the biggest problem we have, and we can solve that. That's already been solved.
Yeah.
Just a business problem.
Yeah. Well, you made the prediction today that in 10 years' time there'll be no more heart transplants, and we'll all.
Well, I think that's a possibility. You know, in 2005, when they just done the rematch trial, and I was at a Gordon conference, which are these government-sponsored conferences, and I said, and in 10 years you won't be using pulsed pumps. And of course, everybody laughed. This rematch trial, they come down. There was a lot of enthusiasm for pulsed pumps. They quit making them in 2012.
So you were right with that prediction.
Yeah, and I don't know if I'll live to see the other prediction, so I'm safe on that one.
Well, if your heart starts failing, we might give you some plutonium maybe,
yeah,
and you'll last 80 years.
But that technology is there, and I think the transplants are wonderful things. They've meant a lot to a lot of patients. That I have several patients that have lived over 30 years with them. It's just that they're good, but we have to try to do better.
Great. Well, it's been an absolute pleasure talking to you, and it was an amazing talk you gave today, and I hope you do see that new era. It's been a real pleasure talking to you. So myself at CTSNet, just like to say thank you very much.
All right.
Thank you.
I appreciate it. Thank you.